Dr. David Denmark, it's great to see you again. How are you today?
Great. Thanks so much for having me back.
Dr. Denmark, for those who are not familiar with you, could you tell us a little bit about your background, including your career and your current role?
Sure. Currently, I'm an interventional cardiologist at Brigham Health, Harvard Medical. I grew up in southern New Hampshire, so I'm a New Englander, but went to school up and down the East Coast. And I've been back practicing here for about 9 years now.
And we're here to talk today about peripheral artery disease. So, what exactly is peripheral artery disease or PAD?
Sure. So peripheral artery disease is a buildup of plaque or atherosclerosis in the blood vessels of the body. When it happens, where most people are familiar with it in the heart, when we have a buildup of atherosclerosis, we can get chest discomfort, angina, and heart attacks. So it's just the same disease process, but consider in the periphery or other arteries of the body, such as the neck, the legs, the abdomen.
And when we talk about PAD, what role does age and gender and genetics play in this presentation of this disease?
I mean, very much like with the heart, males are at increased risk. And As we get older, not only the outside of the body gets older that we all see, but so does the inside. So definitely that plays a big factor of it. And you mentioned genetics, definitely family history. So those are unfortunately what we would consider non-modifiable risk factors. There's the ones we were born with, nothing we can really do about it. They definitely do play a risk and increase that.
And with peripheral artery disease, is it treatable and can it be cured, or is it or treated, and how is it addressed?
Sure, it's a great question. I wouldn't say it's necessarily ever cured per se. There are a lot of things that we can do to treat it, to decrease our risk. I mentioned a little bit about the non-modifiable risk factors. Then we also have modifiable risk factors. So such as smoking cigarettes is a risk factor. Diet, poor diet, lack of exercise are increased risk factors. So if we start with the basics, a heart healthy diet, increased activity, no smoking, the same recommendations we would make for decreasing risk of heart disease would be the same recommendations for decreasing the risk of peripheral arterial disease.
Now, when we talk about treating this disease, and there are, I presume, different levels of treatment, could you share with us what some of those different varieties of treatment might be, depending upon the severity of the disease?
Sure, of course. Once you start with your modifiable risk factors and modifying them, that's would be considered conservative therapy. And then we can sometimes move on to medications, such as an aspirin or other blood thinners. There's also control of your cholesterol. Generally, we'd use a statin type medication. And then depending on once we get into, as symptoms become more and more severe, then we move on to more invasive mechanisms to treat it. And there are several different types of peripheral arterial disease I mentioned in the legs and in the aorta and up in the neck. So there's slightly different medications for different ones depending on the symptoms you may get. But if you fail medications, then we would consider, for the most part, try with a non-invasive procedure, such as an angiogram. We bring you to the hospital and go and take a look to see if there are blockages or where they may be. And then we can either hopefully try to open those up with balloons or stents. And then sometimes if that doesn't work, then I call my surgical colleagues, and it's more of a bypass surgery type issue. But we'll generally go in stepwise approach for the most part. Sometimes we see patients who are extremely sick and they have severe disease, and we know we can't do a minimally invasive approach and they have to go right to surgery.
And when we talk about using balloons or stents, for example, is there a way in which to look at how long that treatment might last before you've got to go back in and either replace the stent or take a more invasive approach, including bypass, for example?
Yeah, great question. So there's a lot of data out there about how long stents may last. For example, I'll just speak about peripheral arterial disease. We'll typically mention the legs, and then a lot of it depends on kind of where we're putting the stents. So different than the arteries of the heart, where the arteries of the heart lay on top of the heart, on the top of the heart muscle, where the arteries in the legs run in between the muscles. And so the issue with that is you can think about it every time you're walking around, your muscles are contracting, you're squeezing those arteries, and there are certain hinge points. So if you're putting metal tubing in that fence and you keep on, of course, you're going to be walking around, you're squeezing that metal. And so stenting sometimes, may not last as long as in the arteries of the heart. Some patients will get, one stent and they're good for 20, 30 years. One patient will get a stent and then it has to be replaced in a couple months. Generally, everybody does it a little bit differently. But when we are taking a look at blockages, we can see a lot of calcium in there. So there are certain tools and tips and tricks we have. So a lot of times I'll kind of use like a drill to try to drill open the calcium and then try to treat it with just a balloon, not putting in any metal if possible, knowing that that may increase the risk of having to come back for more procedures. Then sometimes where we treated that stent, or excuse me, that balloon didn't work in the long term, so you have to bring a patient back to do another stent. Sometimes we use then what we call a covered stent. And lastly, if that doesn't work, it's bypass surgery. But a lot of it depends kind of a lot on where the location is too. As you can imagine, the joints, the hip or the knee, as you're bending your knee all the time, you're bending that metal, increasing the risk of stent fracture, disruption, the regrowth of blockages.
The technology as it applies to treating this type of disease has certainly progressed and has advanced over the years. And so when a patient undergoes, let's say, bypass surgical procedure, doesn't necessarily mean that their active days are over, that they can still return to an active lifestyle. Is that correct?
100%. That's why we do this. And a lot of people, I would encourage people to seek care, to talk to your doctors about this. Unfortunately, a lot of times we see patients and it's a little bit late. Or, for example, when we take a look at blockage in the arteries of the legs, we divide them into generally 4 categories. You could have a short blockage that's not 100% blocked, a long blockage that's not 100%, a short blockage that's 100%, or a long blockage that's 100%. When you get to these long blockages that are 100%, they've generally been that way for years. Sometimes people may not have been noticing they've had symptoms or ignoring them. And then when I take the pictures and I see I have this long blockage that's 100%, I can try to open it, but more often than not, we may need surgery. But we definitely do that so that you can, go and live your life and, don't get the symptoms. So the symptom would typically be what we call claudication, where you get cramping, specifically in the muscle areas of the legs, so back in the calves or in the thighs. Worse when you're exerting yourself or walking up hills or upstairs. That's the claudication. Those are your warning signs to go and speak with someone about that.
That's a very important point that you just raised in terms of what are some of those signs. And so you talked about pains in the back of the calf, particularly noticeable when climbing stairs or maybe going on long walks. Are there other signs that we, particularly men, we tend to ignore because it's like, I worked in the yard all day, or I did this or that, and you dismiss it. Right. So let's really hone in on some of those telltale signs that we are quick to dismiss.
Yeah, that's definitely the biggest one. That's generally one of the earlier signs that you're going to see, is that claudication, that discomfort in the calf or the thigh. Sometimes it can honestly be in the buttocks and the back. The arteries are basically there just to give blood and therefore oxygen to the muscles. So if there's a blockage in the artery and they can't get the oxygen that it needs, then you're going to get discomfort. And to that same point of lack of oxygen in the legs, you may notice, these are generally later findings, but you may notice hair loss down by the ankles or kind of raising up because you're not getting enough oxygenation. You might start noticing wounds that don't heal as quickly. A lot of times when we see patients who it's a more acute issue that we really want to do something sooner rather than later, we see non-healing ulcers or non-healing wounds that become an issue.
So when you go to see your doctor, and let's say that your doctor is a general practitioner and you're sharing your overall general health, would it be at that point of the conversation that you're your attending general physician would refer you to see a cardiovascular specialist?
Yes, I would imagine that, or a vascular surgeon. We both kind of do the same type of work exactly. But if you start to notice this, it would be something to bring up to your doctor, and then discuss what the options are, seeing a specialist, and go from there. Definitely.
So, Dr. Denmark, when we talk about this particular disease and how one might screen for this disease, particularly when, for example, you're visiting with your doctor, you're getting your annual physical. So when and how does the screening commence?
Sure. So a lot of the screening it will be done by your primary care doctor, and it's going to depend on certain risk factors. Are you a smoker? Your age, family history? Do you have any history of vascular disease? Is it coronary or otherwise? And a lot of the ones we'll typically screen for are those that are more asymptomatic until you really have a significant event. We're mentioning peripheral arterial disease, blockage in the arteries of the legs. A lot of times patients will come with symptoms first. So we don't necessarily do screening per se, but if we were to, it would be something that we typically call an ankle brachial index, or ABI, where we just measure the blood pressure in your brachial artery, in your arm, and down by your ankle. So the index between your ankle and your brachial blood pressures can give us a determination of whether or not there may be a blockage in one of the arteries of your legs. Moving up, then we get to our abdominal aorta, and a lot of times we'll do an ultrasound to look to see, is there an aneurysm, an outpouching of the aorta, which, if going untreated, can rupture and be very catastrophic. And a lot of times it's, do you have a first-degree relative with a history of what we call a AAA, an abdominal aortic aneurysm, or are you a smoker? And then moving up to the arteries of the neck, if we have blockages in your carotid arteries, that increases the risk of a stroke. So again, a lot of times that is asymptomatic until you have a stroke, or what we call a mini stroke. You may have heard of a TIA, which is basically stroke-like symptoms that just last under 24 hours. So we don't want to wait till we get a stroke. We don't want to wait until our aneurysm ruptures. We want to catch that sooner. So generally the screening would be your primary care with an ultrasound.
Dr. Denmark, it has been really a pleasure visiting with you and talking about peripheral artery disease, PAD. We hear an awful lot about it, but we're not very familiar with all of the elements that are associated with it, particularly the symptoms, and how does it affect age, gender, and does genetics play a role in any of this? And more importantly, the treatment of peripheral artery disease.
Well, thank you so much for having me. It's been a great time, some great questions. I hope it's been educational.
Thank you very much, and we look forward to visiting with you again.
Anytime.